So, first of all, I would like to thank AFPA for having me here for this lecture. Now, my topic is refractory GERD. So, I am not going to be beating around the bush. Directly, I will hit refractory GERD. Now, most of us will know what is gastroesophageal reflux disease. Most of the patients will present with heartburn, nausea, regurgitation, and many of them will have some atypical symptoms like cough, sore throat, asthma, and the drug of choice is proton pump inhibitors. Majority of them do not require an endoscopy for a diagnosis. A proper history is sufficient to make a diagnosis and start treatment. What happens if the patient doesn't respond? That is what I am going to answer. So, GERD is labeled as refractory when a person has got partial or no response to twice a day PPI. Some of the guidelines say that once a day PPI, if the patient is not responding, then also we should consider them as refractory GERD. How to approach all these patients? So, if we see the reasons, one of the leading reason is related to the medicine. So, if you are given a proton pump inhibitor, the drug doesn't matter, but they act best when the patient is taking the medicines on empty stomach. The once a day dosing, you should take it before breakfast at least 30 minutes. And adherence. So many of these patients do not adhere to the medicine. If you take the medicine after meals, the medicine will not have the effect. If the patient is taking once a day, we have to switch to twice a day. Now, if the patient has got hiatus hernia, there will be an acid pocket in the just below the GE junction, and the patient will have reflux symptoms in spite of being on medication. If the patient has got a non-acid reflux, so if it is a bile reflux or if it is just a regurgitation of gastric contents which are not significantly acidic, then the patient may not respond fully to PPI. Now, reflux hypersensitivity or functional heartburn. So, જેમ આપણી પાસે બહુ બધા ફંક્શનલ ડિસ્પેપ્સિયાના પેશન્ટ હોય છે કે જેને એન્ડોસ્કોપી નોર્મલ હોય છે, મ્યુકોઝામાં કંઈ પ્રોબ્લેમ નથી હોતો, બટ દે કીપ ઓન હેવિંગ સિમ્ટમ્સ. Similarly, there is an entity known as functional heartburn. So, patient will have reflux symptoms, છાતીમાં બળતરા થાય છે, but there will be no acid reflux. Esophageal stricture or malignancy is something which we have to keep in mind. Other diagnoses: eosinophilic esophagitis, pill esophagitis, infectious esophagitis, patients of scleroderma, or motility disorders like achalasia, distal esophageal spasm, jackhammer esophagus. Those patients, especially elderly patients who are diabetic, will have some amount of gastroparesis and they will have refractory GERD or gastric outlet obstruction. Zollinger-Ellison syndrome is not that common, but we have to keep in mind. Now, how to approach all these patients? We have to ask a proper history, the duration of the illness, the medication history. We have to ask what are the symptoms, whether it is just heartburn, regurgitation, atypical symptoms are there or not. Concomitant dyspeptic symptoms, postprandial fullness, vomiting, especially if it is after meals, which is causing relief of symptoms, may just suggest gastric outlet obstruction. Now, dysphagia and odynophagia per se are not symptoms of GERD, but those patients who have severe reflux esophagitis can present to us with dysphagia and even odynophagia. Odynophagia is pain while swallowing, and dysphagia is difficulty in swallowing. Other diagnoses like peptic stricture in the esophagus, malignancy are to be kept in mind when there is dysphagia. Similarly, we have to ask for weight loss, anemia. Other medicines, as Dr. Bhavesh also said, so patients of GERD, when they are taking calcium channel blockers, NSAIDs, steroids, may have more reflux symptoms in spite of being on PPI. So this is something which we have to keep in mind. In workup, the first test which we do is an endoscopy. So if the patient has got a normal endoscopy, that doesn't rule out reflux. So majority of patients who have got GERD will have a non-erosive reflux disease, where the endoscopy will be normal. It doesn't rule out that patient is not having reflux disease. If there are endoscopic findings, we will see either a small tear which is less than 5 millimeter, longer tear more than 5 millimeter in length. Grade C esophagitis is when there is an ulcer which is bridging the mucosal folds, and if there is circumferential ulceration, it is labeled as LA grade D esophagitis. Another thing is, when we are doing an endoscopy, we do a J maneuver and we assess the G junction flap wall mechanism, and this is the Hill classification which is used. So if the G junction is snugly fit to the endoscope, it is labeled as Hill grade 1. If it is not snugly fit and if during inspiration it is relaxed, it is labeled as Hill grade 2. Now this is very important when we are planning other treatment for patients of GERD. If there is significant gap, it is labeled as grade 3, and when there is large hiatus hernia, no opposition, it is labeled as grade 4. Now sometimes endoscopy helps us in providing alternative diagnosis. Like this patient had pill esophagitis. You can see 2 kissing ulcers in the esophagus. So the pill was stuck, and because of that there is esophagitis. These are herpetic ulcers. Herpes infection, CMV, can cause viral esophagitis and the patient may come with heartburn. You can see these small white dots. This is a patient with eosinophilic esophagitis, and these are all eosinophilic microabscesses. This disease will require entire different treatment. So alternative diagnosis has to be positively looked for. This is another patient who had ulceration, circumferential ulceration along the entire length of esophagus, and this patient was having pemphigus. So the esophageal involvement of pemphigus. Now age-old study, barium is not used that commonly nowadays. Of course, it has got very limited utility in the era of endoscopy, but there are certain things which can be picked up by a barium study. So if a patient has got a hiatus hernia, it will be picked up. If a patient has achalasia cardia, it will be picked up. If the patient has got a malignancy, we will be able to identify it. The gold standard test for GERD is a 24-hour pH metry and impedance study. So this can be done in an ambulatory setting. A small catheter is inserted through the nose and the patient is allowed to do all the normal activities including eating, and whenever the patient has got a reflux, he is supposed to notify it. So if we do a 24-hour, there are various graphs, various criteria to determine whether the patient has got a reflux or not. So we will get 3 scenarios. One is a patient has a normal study. So these are patients who have got reflux hypersensitivity or they have got functional heartburn. They do not require high doses of PPI. They require medicines like tricyclic antidepressants, SSRI, and explanation, counseling to them that the patient is not having significant reflux. If it is positive for weakly acidic reflux, these patients may help with medicines which decrease the lower esophageal sphincter relaxation, prokinetics, and sometimes we need these patients to be treated with anti-reflux surgery or endotherapy. When it is positive for reflux, what all modalities we have? So first and foremost thing is lifestyle modification. Then we modify the drug. We have got newer drugs like PCABs, the vonoprazole. We add a nighttime H2 receptor antagonist or a locally acting agent like sodium alginate or sucralfate, and then we go for anti-reflux surgery or endoscopic modalities. Now lifestyle modification, these are very, very important. We need to emphasize to all patients of reflux disease, if a person is obese, the intra-abdominal pressure will be more chances of having reflux. So weight loss is very important. Taking small frequent meals which avoids over distension of the stomach decreases the reflux. Having an upright posture, especially after meals. Elevating the head end of bed just by 6 to 8 inches without using excessive pillows. This is important because otherwise it will not achieve the purpose and the patient will have spine related issues. Avoiding smoking, alcohol, coffee, chocolate and fatty foods help. Any activity which causes sudden rise in intra-abdominal pressure can also increase the reflux. So this has to be explained to the patient. Now we do esophageal manometry. Now it has got as such very limited role in refractory GERD, but we do a manometry to rule out motility disorder, number 1, and number 2, if the person is planned for a laparoscopic fundoplication, we need to do a manometry to rule out motility disorder. If the patient is having failed peristalsis, we cannot do a complete fundoplication, we have to do a partial fundoplication, otherwise post-operatively the patient will end up with dysphagia. Now just highlight few modalities which we do endoscopically. So if there is GERD, patient has got Hill grade 1 or 2 anatomy, there are certain procedures which can be done endoscopically, and one of them is ARMA, which is anti-reflux mucosal ablation. So we just do a normal endoscopy, we burn the area in the fundus of stomach just below the GE junction with the help of APC to around 270 degrees to 300 degrees, and this will cause some scarring and increase in the GE junction pressure. Other modalities are Gerdex, which basically does a full thickness stitching of the gastric cardia and fundus, and the Isofix device, which creates a proper fundoplication of 270 to 300 degrees endoscopically in patients of reflux disease. These all can be offered to patients who have not got a large hiatus hernia, and the benefit is it saves the scar of laparoscopy also. Now just a word of caution regarding the use of proton pump inhibitors. Many of our patients are taking proton pump inhibitors for long term. As such, they are a very safe drug, but they increase the chances of developing funny gland polyps. Vitamin B12, iron deficiency, calcium, magnesium deficiency has been reported with PPI. Increase in the risk of community acquired pneumonia, enteric infections, especially those patients who are cirrhotics. If they are on PPI without any proper indication, there is a significant increase in the risk of spontaneous bacterial peritonitis, C. difficile colitis or pseudomembranous colitis, and rarely the patient will develop acute interstitial nephritis. So we have to remember that every drug has got a side effect. To conclude, all patients of GERD do not require endoscopy. Many patients who are not responding to PPI may not have erosive GERD, or they might just be having reflux hypersensitivity, which requires de-escalation of treatment. 24-hour pH-metry and impedance study is the gold standard for proper treatment, and many newer endoscopic modalities are there in the pipeline. Thank you.